6 o'clock.
All right. Well, hello. Kyle Allred here, co-founder of MedCram.com and course producer here. And I'd like to introduce Dr. Roger Seheult. And for those who are new to us, Dr. Seheult has 4 board certifications: critical care, pulmonary, sleep medicine, and internal medicine. And Dr. Seheult is also an associate professor at University of California, Riverside. And I'm going to bring in Dr. Seheult now. How you doing, Dr. Seheult?
Very good. Thanks, Kyle.
And you just got out of the ICU and had a shift today. We're kind enough to get right on the computer and join us. How are things going at your hospital right now?
Well, it's busy, and we're in California. We never really flattened the curve too much. We're probably at our highest amount right now, slowly increasing, and now with things opening up, it looks as though we may be increasing as well. Have a number of COVID-19 patients that have come in. Some of them are on ventilators, and we're working through the issues.
Okay, well, I want to start with, we had a lot of great questions over the week. Thank you all for posting your comments and questions on our website, medcram.com, and on our YouTube channel. And a lot of questions about studies. So I want to start with a couple. First of all, a resource that some of you may be aware of. Let me get out of this one here and go to, there it is. So this is clinicaltrials.gov, and these are all of the COVID-19 studies going on right now. You can see up here there's 1,982 studies for COVID-19. This search was just using the search term COVID-19. And you can see what the interventions are. So you can see what medications or vitamins or other types of interventions that they're utilizing in these studies, and whether or not they're recruiting, what country they're happening in. So we thought this was a great resource. Obviously, there's no way to keep up on what's going on with almost 2,000 studies, but we are doing our best, and a lot of you, we appreciate it, pointed the way for us to check out new studies that we weren't aware of. But we also thought it would be interesting to just review, and we know we have both medically trained viewers of MedCram, clinicians, and also non-medical folks. So we thought this would be a good review for Dr. Seheult, just to go over the 2 main types of studies: experimental studies and observational studies, and the importance of both, but also potential limitations and problems with both. So I'll turn it over to you with that, Dr. Seheult.
Thanks, Kyle. Yeah, so the 2 major types of studies are the observational and the experimental. Experimental is where actually you intervene, you do something. There's a control group and there's an intervention group. Whereas observational studies, you're simply observing, you're watching, you're looking, you're seeing what happens when certain things occur. And there's certain biases that appear with observational studies. The key thing to understand with observational studies is you really can't draw hard conclusions from a retrospective looking back observational study. I think a good example of that would be, for instance, if you were to, let's say, do a study where you say, let's look at people who have cigarette lighters in their breast pocket and lung cancer, and let's just see what happens when we look at those. And sure enough, you probably would find that cigarette lighters are associated with lung cancer. Cigarette lighters in someone's pocket is associated with lung cancer. And you would say, aha, this is it. You put a cigarette lighter in your breast pocket, you're going to get lung cancer. And of course, that's not the case. That's an observational study. There's an association. People who tend to have cigarette lighters in their breast pocket tend to get lung cancer. So how do you actually determine whether or not that's the case? Well, you would do an actual experimental study, an intervention, where you would randomize people. And in some people, you would put cigarette lighters in their breast pocket, and other people you wouldn't. And sure enough, you would conclude at the end of that experimental randomized controlled trial that cigarette lighters in a breast pocket, of course, does absolutely nothing in terms of increasing the incidence of lung cancer. And then you would have to conclude that that was a confounder. Yes, cigarette lighters in a breast pocket usually means that people are smoking. So it's associated with the real cause of the lung cancer, which is actually smoking, as we know. So that's an interesting an analogy, and you have to be careful that when you look at some of these observational studies like we've looked at, we saw that there were observational studies, for instance, that showed that hydroxychloroquine was associated with an increased risk of mortality. Well, that could be because people who are sicker are being put on hydroxychloroquine, and that's why they're dying. Or it could also be that it could very well be that hydroxychloroquine could be increasing the amount of deaths. We just don't know from an observational study. We have to do a randomized controlled trial, and that's when we'll get it. And so that's the other part of that graph, is that is the fact that that graph, which it shows on the top part, we have the experimental studies, and on the bottom part we have the observational studies. And so observational studies are things like cohorts, case control studies, cross-sectional studies. These are the things that are readily available early on in the pandemic that we've talked about here with COVID-19, and that's why these are not the most helpful, but they're the ones that can come out fastest. The ones that take some time are the experimental. You have to set up a placebo arm. You have to set up an intervention, a control group. Watch them over a prospective amount of time. So going forward, looking at them. Those are your randomized controlled trials and your non-randomized controlled trials. So those are the prospective studies. Those are not the ones that you would see with bias, but you can actually do a test. And you can see that in Kyle, let's just throw up the triangular graph. Where do they fit in the larger scheme of trials? And before we get to that triangular graph, realize that observational studies, what are they good for? They're really good at bringing forth hypotheses. So it's a hypothesis-driven question. So if you have an observational study, you say, hey, look, it seems as though A is associated with B. We don't know if it causes it. We just know it's associated with it. Going back to our first example, we could see that cigarette lighters are associated with lung cancer, but we don't know if it actually causes it. The only way to do that is to do the actual randomized controlled trial. So again, observational studies, retrospective studies gives you the ability to make a hypothesis, but the only way to test that hypothesis truly is to do the experimental study. So if we look at the big scheme of things in terms of the big pyramid, at the very bottom, we've got lab data, animal and laboratory data. So we're not even talking about human beings. We're talking about in vitro animal studies. That's kind of at the bottom. Then there's case reports. There's notice expert opinion, right? So even if somebody's an expert and they say, hey, I think this, it's really at the bottom of evidence. We really don't go off of expert opinion. We go off of what studies show, because experts can be biased. The next level of evidence is the case-controlled study. That's the observational study like we just talked about. And of course, the cohort study. So that's the yellow and the green there. Those are studies that are retrospective, observational. And then above that is the sort of the king there, which is randomized controlled trials. Those are primary studies, otherwise known as pivotal studies. They're typically phase 3 studies when you're talking about vaccines or medications that are going for FDA approval. And then you've got on top of that, so those are just individual studies. On top of that, you've got meta-analysis and systematic reviews. These are where you look at multiple randomized controlled trials and you put them all together into one big massive meta-analysis. And then you sit down and you review these things and you look at practice guidelines, which are sort of at the top and represent a conglomeration of randomized controlled trials. So you can see there that when they say a study just came out, your first question is really a study came out? What kind of study just came out? What kind of data are we talking about? What is the evidence that we're talking about? Because not all studies are the same. So when we talk about benchtop studies that show, hey, look, in a test tube, zinc inhibits coronavirus RNA-dependent RNA polymerase. Great. That's a study that's near the bottom in terms of evidence. That's not a randomized placebo-controlled trial where you have thousands and thousands of people taking zinc and you're randomizing and saying, yep, this works. This is at the bottom. And so whenever you have evidence at the bottom, what does that mean? That means that you got to do a study one rung up and keep working your way up until you finally get to the tip of that pyramid. And then you know you've got the evidence to prove, to show that that's where you are. So what in COVID-19, where are we with what? Okay, so the probably the medication that has shown the most evidence, it's the highest up on this pyramid, is remdesivir. Why? Because we actually have a randomized placebo-controlled trial, multi-center, that showed benefit and evidence. Interestingly, Kyle, buried in all of that news about the Lancet and the New England Journal of Medicine getting their articles pulled because of Surgisphere's data issues, there was also a randomized placebo-controlled trial of hydroxychloroquine without zinc that showed that it was not beneficial. So that's also pretty high up evidence. That would be in that sort of that baby blue on the triangle there, pretty high up. And that's kind of where we are right now. In terms of vaccines, we're way back at phase 1. We're still doing patient safety trials. We haven't even gotten to dosing really, or even into phase 3 trials. So everything else that we're going to talk about in terms of treatment, whether it's vitamin D, that's a case controls trial, whether it's vitamin C, whether it's zinc, whether it's any kind of supplement, really, we don't have that high level of data as yet. So I hope that sort of answers the question, and we went through that pretty systematically, Kyle, and I think people just need to kind of keep that triangle in mind. And this is something that you want to think about. Whenever there's a study that comes out, ask yourself, what kind of study was this, and where does it fit in the hierarchy of evidence?
Excellent. Very helpful. Thank you, Dr. Seheult. So I want to get to some questions. Got a lot of live questions coming in. The first one that I was able to grab is from Paul Elliott. And Paul said, could something be wrong with science's fundamental assumptions about COVID-19? So kind of an open-ended question. What are some of the ways you think that we don't really know what we're dealing with yet?
Well, it depends on what the definition of those fundamental assumptions are. I think we have assumed that it's an RNA virus. I think that's pretty solid. That it's a virus, I think that's pretty solid. How it affects the body, you know, all bets are off there. We initially thought that this was going to be like a bad influenza or a cold, and so we were looking at ARDS. Clearly, Gattinoni out of Italy showed that there's two types, two phenotypes. That was sort of thrown into question. How about the endovascular aspects of COVID-19? That was thrown into question. How about all these ventilators that we needed? That was kind of thrown into question. So yeah, science is always asking the question, are we making the wrong assumption here? Are we going off of expert evidence when we really should be going on data? And part of the problem is that this thing is fluid. It's unfolding right before our very eyes. And how it may behave in China or in, South Korea or even Germany or Italy may be different than how it behaves here in the United States for us. And it's always this perennial problem. The more you generalize, the bigger your studies become, the less able you are to make them specific to the individual sitting in front of you because it's so generalized. You get a statistically significant result, but how do you apply that to the individual? So we know what's happened in Asia and in Europe, but what does that tell you about what's going on here in the United States? Is the virus changing? Is it becoming less virulent? Is it becoming less dangerous? Is it becoming less infective? We just don't know. We don't know the answer to that question. So we always have to be asking that question and always reviewing. Is it something that we're missing here? I think it's a good question.
Great. Joseph B. wants to know, will we have a second wave in December that will be more lethal than what we're dealing with right now?
So the question is whether or not we'll even have a second wave. It could be because of the weather. It could be because of opening up. I think if it's in terms of the weather getting colder, and that's when we start to see more viruses, or it could be that because we get less sunlight and vitamin D levels go down, people get more sick. I think we're going to get a sense about that looking at New Zealand and Australia. They're heading into winter now, and they pretty much crushed the curve if you look at Worldometer. Let's see if they start to spike again. Let's see if they start to go up. If they do, then I think the chances that we're going to see something here in the United States or in the Northern Hemisphere is pretty good. Whether it's going to be worse, I'm hoping that's not the case. I think we've geared up. We're ready for it. We've got more testing. We've got more PPE. We'll be ready for that. We've got more medications down than we did the first time around. Hopefully we'll have even more. So I don't think it's going to be more deadly unless, of course, we've opened up so much that we're just overwhelmed, like what happened in northern Italy a couple months ago.
And thank you, Dr. Seheult. David Plotkin had a question about nitric oxide. And we're seeing nitric oxide in the news more. We know Tufts Medical Center is doing a trial involving nitric oxide. So could you talk a little bit about nitric oxide? And then David's specific question in there is, he's under the understanding that African Americans may have a lower level of nitric oxide inherently, and could this increase susceptibility? So
I was reading about that as well. It certainly is possible. You know, the key to getting oxygen into the blood is to get the blood flowing where the oxygen is moving into the alveolus. And if you get the oxygen not meeting up with the blood flow, you're not going to get good oxygenation into the blood. So the nice thing about nitric oxide is that you're inhaling nitric oxide. Nitric oxide is a vasodilator. And so whichever alveolus, that's the portion of the lung that accepts the oxygen and the ventilation, wherever the nitric oxide goes, by definition is going to be where there's ventilation occurring. And so it's going to predominantly vasodilate sections of the lung that are getting well ventilated. And so you're going to get good ventilation perfusion matching. And that may improve your ability to oxygenate the blood better. There's a number of other things that are working on that in terms of medications. There's other medications like sildenafil, other phosphodiesterase type 5 inhibitors that also vasodilate. So yeah, this is something that is being looked at. In fact, there is a medication, I believe, coming out of on the East Coast where they actually are nebulizing nitric oxide for patients to breathe and hopefully be able to go home and stay home and improve oxygenation without needing oxygen supplementally. That's still in the early stages. They're still looking at that. Some hospitals don't have access to inhaled nitric oxide, so unfortunately that's not available everywhere. But in the places that it is available, it is an interesting intervention, and I think studies are being done on that.
Great. A lot of questions coming in about blood clots and ways to prevent them, both in the hospital and potentially as just preventative, to prevent potential blood clots, even if someone doesn't have COVID-19 or is not sick. So kind of a two-part question. Number one, what are you doing in the hospital setting to prevent blood clots for COVID-19 patients? And number two, would you recommend any type of supplement or something people should take at home to kind of prophylax for blood clots in case they get COVID-19?
Good question. So, you know, most patients who are admitted to the hospital with or without COVID-19 are usually put on one of two forms or even both forms of prophylaxis to prevent blood clots, or DVTs as we call them, or VTEs, venous thromboembolism. And that's some sort of heparin or low molecular weight heparin like Lovenox, or a sequential compression device on the legs to make sure that the blood is flowing. But it seems as though that some people are going above and beyond that and actually putting them on therapeutic doses, not just prophylaxis, but the type of dosing that we would give to people who have actual blood clots. And that's interesting because as we've seen recently, there was a New England Journal of Medicine article about 3 weeks ago that showed that patients' autopsies on lungs had 9 times the amount of micro blood clots in the pulmonary system area. So when do we put these people on this regular dose or high dose heparin, Lovenox, some of these novel oral anticoagulants? You know, there's no real consensus out there. There are a number of hospitals with protocols. Some of them are determining this based on how sick these patients are, how low their oxygen is. Also looking at something called the D-dimer. D-dimer is a product of coagulation, anticoagulation, and the higher that number is, the more it appears as though there are more clots forming in the patient. So we have to be careful though with these anticoagulants. On one side, of course, we can prevent blood clots from forming or maybe even dissolve the ones that are there over time, but it can also cause bleeding. And so bleeding is a well-known risk factor for starting these medications. And in patients who have risk factors of bleeding, even patients who don't have risk factors for bleeding, you can get bleeding complications. And so that needs to be looked at very carefully.
Any thoughts specifically? I've seen, let's see, Patricia and Jim writing in about vitamin K for preventing blood clots. Any thoughts on vitamin K?
So vitamin K actually is an essential vitamin for the ability to make coagulation factors. So 2, 7, 9, 10, factors 2, 7, 9, 10, C, and S, both and all need vitamin K, different forms of vitamin K, of course. Vitamin K, generally speaking, if you take too much vitamin K, you're actually going to be hypercoagulable. And so one of the forms of anticoagulation is Coumadin or warfarin, Coumadin analogs, warfarin analogs, which essentially block that ability to utilize vitamin K, and that causes the blood to be thin. So vitamin K actually can cause a hypercoagulable state or prevent you from being anticoagulated. So you'd want to be careful in terms of that.
Okay. Username, or maybe it's their name, Nat wanted to know any insights on melatonin supplementation, which seems to have potent antioxidant properties. And Dr. Seheult, since you're a sleep specialist as well, I'll expand this into a two-part question. What are your thoughts beyond the potential antioxidant properties of melatonin? What are your thoughts on that as a sleep aid? You've talked about how sleep's important to help bolster our immune systems and potentially prevent infection. So could you speak to it on for sleep as well?
Yeah, so first of all, they're right. Melatonin is a pretty powerful, potent antioxidant and can be very beneficial in patients who have oxidative stress, such as people with COVID-19, we believe. So that's a reason there to even be on melatonin. Secondly, melatonin also has the ability to do a couple of things in terms of sleep. Number one, it can advance the circadian rhythm if it's given in the evening time, in terms of when there is your own body's melatonin that comes on. It's known as dim light melatonin onset, or DMLO. That can advance your sleep phase. So if you're someone that likes to go to bed later, it can actually advance your sleep phase by about an hour or so. By the way, you can do the same thing by exposing your eyes to bright light early in the morning. Advancing your circadian rhythm can do that. But also, taking melatonin not only advances your circadian rhythm, but can also cause you to fall asleep. And in terms of people who have sleep onset insomnia, it can actually be pretty beneficial for them. You have to be careful, though, in terms of the dosing that you take. I wouldn't recommend taking higher doses. So if a dose doesn't work, I would actually recommend cutting the dose, reducing the dose. 3 to 5 milligrams is probably the optimal dose in terms of sleep. Taking much more than that, 5 to 10, may just make you more irritable, and I wouldn't recommend taking that kind of a high dose.
Great. Had a comment here from Sarah P. She said, we are using nitric oxide at our hospital with some success. So that's good to see that it's already being used.
It's great news, yeah.
And I'm curious if Sarah wants to write in if that's part of the clinical trial that's going on, or if that's just something that your hospital has implemented. Another hospital-based question from John Person. What's the average length of hospital stays for your patients, Dr. Seheult, that come into the hospital or ICU with COVID-19?
It's pretty long. There's some patients that maybe are there for about 4 or 5 days on the short side. We've had patients here for weeks, and I understand that's not too unusual. I've seen some news reports of patients leaving the hospital that have been there for literally weeks and weeks on end, and they're finally just getting better now. So we're seeing a wide spectrum of patients. We're seeing a wide spectrum. Some of them are there for weeks, some of them are there for days, and then they get better. But it's not fast.
So speaking of patients being in the hospital for a long time or in the ICU, presumably those patients are on respiratory support of some kind while they're there, correct?
Yeah, that's right. Absolutely.
So we've had a lot of questions about ventilators and ventilation in the critical care setting. And could you just help, and this is going to, again, be review for some of the clinicians watching this, but I'm going to pull up a chart here. And this is a great chart that was put together by Pulmcrit. It's from their Internet Book of Critical Care. And it just shows the progression of oxygen therapy that one would receive potentially in a hospital stay. So I'll turn it over to you, Dr. Seheult, to explain this and give it some context.
Yeah, so basically you need to give increasing amounts of oxygen, but you have to have it deliverable in a way that the breathing in doesn't exceed the amount of gas being given, right? So if someone is just bleeding in at 3 liters per minute and you're breathing in faster than 3 liters per minute, certainly you're not going to be getting the same amount of oxygen. So as the amount goes up, the amount that you need to take in goes up, so does the amount of flow needs to go up as well. So at the beginning stages, we have a little nasal cannula, which are little prongs that go into the nose at first, and that can be anywhere from about 1 to 6 liters per minute. You can see there on the low flow nasal cannula. That's sort of the first step. That's what the paramedics might do for you when you get picked up or when you come to the emergency room, and they put you on that. The second one would be high flow nasal cannula, and that's where we actually just put in about 40 liters. We can go up to about 40 liters per minute in that situation, where there's just a tremendous amount of gas flow going into your nose and into your lungs. And in addition to giving you a lot of oxygen that way, it also puts in a positive pressure environment in your lung that tends to open your lungs a little bit better and get better gas exchange. The FiO2 is simply the fraction of gas that you're being given that is oxygen. So 50%, FiO2 would be 0.5. Obviously, the lowest that we can give is 0.21. That's room air, as we call it. We can go all the way up to 1.0, which is 100%. From there, you can go CPAP. CPAP's where you actually have a continuous positive airway pressure. This is where you have a mask that fits and seals around your face and is putting air at a constant pressure. This is what a lot of people use when they have sleep apnea. They use this at home. That's a CPAP machine. What we can also do is go to BiPAP. So when a person takes a breath in, it gives a increased pressure on breathing in, and then when the patient breathes out, it goes back to that lower pressure. That's BiPAP. That aids the patient in breathing in and out. We can also have the patient flip over on their belly. We've talked about this before in terms of ARDS. There is some improved survival data in patients with lack of oxygen from ARDS when they are lying on their belly. There's an improvement in oxygenation and in survival in severe ARDS. That was published a number of years ago in the New England Journal of Medicine. Pretty good data out of France, and we've been doing it since. And I can tell you, Kyle, I see it in all the patients, really. Patients that are prone, they almost immediately have an improvement in their oxygen saturation. So if that doesn't work, the next step, of course, is mechanical ventilation. We can still prone those patients as well. Mechanical ventilation is where we put a endotracheal tube down into the mouth, past the vocal cords, into the trachea. A balloon is inflated around the tube to prevent gas from escaping out, and we can actually ventilate patients, pushing their air in and out. Why would we do that? Well, we would do that because the patient can't breathe on their own, or they're struggling to breathe, or they're becoming tired and they won't be able to breathe. Typically that happens when their respiratory rates get above 30, when their tidal volumes are becoming slow, and they're just feeling very tired. So that's when we would do that. And we've really tried to avoid putting people on the ventilator in COVID-19, but of course, if people don't have the strength to breathe, we've got really not much choice. You can give them as much oxygen as you want, but unless they can actually move air and have the strength to move air, you're going to need to be putting them on ventilators. The final one there is VV ECMO. This is basically where you can choose to bypass the lungs completely. It requires you to have a good cardiac pump to pump the blood around, and it's basically a heart-lung machine, but you're using it around the clock in a patient who's not in the operating room. They're just in the intensive care unit. And you do it for as long as you possibly can so that their lungs improve. Now, to do that, though, you've got to put them on anticoagulation, because otherwise you can get blood clots forming in these heart-lung machines. And also realize, Kyle, that you can get some issues with the brain in ECMO as well. There are some concerns that people can have breakage of red blood cells, shear stress, releasing cytokines, and that can cause issues in the brain as well. So that's kind of from the lowest all the way up to the highest. And people have asked that question, why don't we just bypass the lungs? Well, ECMO machines are not, they're not very common. Let's say they're even less common than ventilators. And so you've got to choose well about this. And really, the data has shown that ECMO machines have not really improved mortality in these kind of situations where you have influenza, pandemics, things of that nature. So I hope that answers the question in terms of the deterioration in one direction and the recovery in the other direction.
Yeah, I think that helps a lot. So, and in summary, if someone were to say, I've heard ventilators are not that helpful for a lot of patients with COVID-19 and they could actually be doing harm, why don't we just keep patients on a non-invasive form of ventilation like CPAP, like BiPAP, like nasal cannula with high flow? What would be your response specifically to that concern that people in the media may have, for example?
Yeah, so the problem with keeping people on non-invasive ventilation like BiPAP, CPAP, things of that nature, is that almost certainly there's secretions that form and they're never able to be cleared because of the BiPAP. When someone is on a ventilator, you're able to actually put a ballard down through the endotracheal tube and occasionally suction the secretions out. These secretions become dried in the back of the throat because of the airflow through there, and it's not a very hygienical situation. They can get obstruction from the secretions. So really, secretions are an issue neurologically. If they're not able to protect their airway, they can regurgitate, they can aspirate down into their lungs. And so when you're getting to that point where they're becoming, not responsive, when they're becoming to the point where they're tiring out, they can't breathe very well, endotracheal intubation is really the way you want to go. It may not be helping, but I would say it's not causing. I would say that it's not causing the excess deaths in these patients. The ventilators that we have today are pretty safe. They're not really able to push a lot of air in. That's not to say that there are no adverse events from ventilators, but I don't believe that the reason why people have such a high mortality rate on ventilators is because the ventilators are doing the problem. I think a more likely explanation is that the ventilators really aren't getting to the underlying condition that's causing the mortality in the first place. And for that, I would think that a much higher suspicious etiology would be something in the realm of the ACE2 receptor, oxidative stress, oxidative reduction, things of that nature, because these are the very people that we're seeing pathology in the first place, right? We're not seeing a lot of people with COPD and compromised lungs. What we are seeing more often are patients with elevated BMIs, people with diabetes, hypertension, kidney failure. These are patients with oxidative stress, and I think those are the patients that are out of balance, and when they get the virus, it's the straw that breaks the camel's back and tips them over the edge. Kyle, we've been keeping people on the ventilator for days, for weeks, and they're very, very slow to recover. I don't believe that that's a result of just a severe super ARDS. If you look at the data, the trial data in the New England Journal of Medicine, whether you're talking about low tidal volume therapy, whether you're talking about paralytics, whether you're talking about prone positioning, all of those control arms in all of those very, very good trials had mortalities in the 40 to 50% range. We're seeing mortalities much higher than that. So this is something different than just your run-of-the-mill ARDS, in my opinion.
Thank you for that. We have a lot of questions, just practical questions, people describing their work environment and as their economies are opening up to varying degrees in different states. Questions about going to restaurants, going back to work where they might work closely with other people. Roger, I know you're not an epidemiologist, but what are some general things that you're thinking about and general suggestions? And to help give this context too, we know there's a new Lancet article that described physical distancing and some of the benefit from that. It looked at masks, it looked at eyewear, and it showed some, though they had low confidence in the findings, some benefit for eyewear as well. So somewhere in there, if you could speak to eyewear too, and if you'd recommend that just in the public setting, wearing sunglasses, wearing some type of eyewear when you go to the supermarket.
Yeah, so that Lancet article was published on June 1st, and really what it was looking was a number of studies. They actually looked at quite a number of them, 172 observational studies across 16 countries, and they looked at the transmission of the viruses in terms of distancing and things. And their interpretation of the results were, and I'll quote here, they said the findings of this systematic review and meta-analysis support physical distancing of 1 meter, that's about 3 feet, or more, and provide quantitative estimates for models and contact tracing to inform policy. Optimum use of face masks, respirators, and eye protection in public and healthcare settings should be informed by these findings and contextual factors. Robust randomized trials are needed to better inform the evidence for these interventions. And again, here, going right back to what we talked about at the beginning, these were observational meta-analysis looking at data from 172 studies. So they're hypothesis forming. And it seems as though that might be the hypothesis that could be used at this point. The question is we need to confirm those observational findings. You know, I go back to I think it's the first law of thermodynamics, which is that entropy always increases. So imagine yourself, if you've got 50 people in a room and, you know, 1 or 2 of them have coronavirus and they're coughing or whatever. So the virus particles will distribute evenly eventually in that room, okay? And somebody, depending on the airflow, might go ahead and breathe that in. Now, if you compare that to being outside, where instead of a room, you have the entire atmosphere of the Earth for those viral particles to dissociate into, you're going to see very quickly that entropy is going to increase much more dramatically in an outside environment than it is going to be in an inside environment. So if I were to say, or if I were to make any advice just on the surface, outdoor events are going to be primarily safer, I believe, than indoor events when it comes to the same number of people. This is going to be very interesting because this certainly takes place. That again, this is expert opinion. We need to do randomized controlled trials to find out. But you can imagine sporting events that occur inside versus outside. You can imagine events, wedding events that can occur inside versus outside. And so you can see very quickly that, you know, barring circulation of air, that's one event right there. That's one variable. You know, is this inside or outside that could have a big impact on the chances of getting the virus.
Great. Have a question here from Quentin Baca. Any fasting benefits to improving our immune system? And I'll add to that to potentially prevent infection from COVID-19.
Yeah, so there's a lot of good data. There was I think this really got set off a number of years ago. There was a great study out of USC that actually had more to do with oncology and chemotherapy. They found that the patients that fasted, I think the quote out of that article was, basically rebuilt their immune system. It was quite dramatic. So there's no question, I think, and this has been followed up in a number of other studies, the actual cells, the ability to rebound, the ability to take care of infections was dramatically improved from all surrogate markers when patients fasted. And so this is something that's being looked at. I believe that we're going to get more evidence for this. Again, this is benchtop. This is laboratory. And according to our pyramid of studies, this is going to be at the bottom, right? But it was in human beings. So I think what we need to do is wait and see the studies. I haven't seen any studies yet for fasting and COVID-19, but I think that's going to be important to see what happens in terms of that. Now, fasting, of course, is also connected to nutrition. It's also connected to dietary patterns, BMI, and so that could also be effective in terms of oxidative stress. So fasting times 1, you know, may rebuild your immune system. It may do that, whereas fasting on a routine basis may do that as well. But in addition to that, may actually improve your BMI, improve your balance of oxidative stress, and may reduce your susceptibility to getting COVID-19. We just don't know yet. We got to see those studies, but certainly that's definitely there in terms of prime time.
Excellent. So a lot of comments because one of the recent studies that we talked about was from the Lancet, and of course the Lancet and the New England Journal of Medicine have retracted recent studies that we covered in one of our updates, and that of course has a ripple effect through the medical community, and it shakes people's confidence, of course, in these publications. What guidance could you give, or how are you thinking about this, Dr. Seheult? I mean, should we throw the baby out with the bathwater and say, well, a lot of these medical journals are potentially political or skewed, or do you think this was a mistake that they made and these mistakes happen? How do you assess this situation?
So let's just dispense with the idea that science is always pure and is never affected by bias. Okay, so if anybody thinks that, then I've got land in Florida to sell you. What we try to do is we try to make sure that we're as insulated from those biases as much as possible. That's the whole process of peer review. That's the whole process of looking at this and having scientists look at this. This is something that the Lancet does not want to have happen ever again. And so they're going to be making sure that that this doesn't happen. What happened here? What happened here is something that's relatively new. Prior to the advent of the electronic health record, we would never have had a situation exactly like this. Why is that? Because this company, known as Surgisphere, apparently goes in and is able to de-identify information in multiple different types of electronic health records, and they're able to gather them up and to do research on this. This is what Kaiser does. Of course, they have access to their own electronic health record, but more than Kaiser, which is a healthcare provider here in California and many other states, this was an international, multinational, multi-continent, basically culling of information to present it. So that really hasn't happened on this kind of a level before, because we've never had electronic health records that ubiquitous. So what's happened here is that the data wasn't being able to be reviewed by the authors. They trusted that the data from the culling organization, in this case Surgisphere, was true and accurate. And when there was signs that that may not have been the case, they wanted to investigate further. When they were not allowed to investigate because they couldn't verify the data, they decided to recommend that their own paper be pulled down from the Lancet. And the same thing happened over at the New England Journal of Medicine. So certainly we don't want to throw the baby out with the bathwater. Certainly, if there's a paper that's published where the authors have access to their data and they can show the data, does that mean that data has never been corrupted before? No, it doesn't mean that. But to a certain point, there's got to be at least people signing on and realizing that if they mismanage the data or if they misrepresent the data, their days in terms of publishing are pretty much limited because of that. You just don't do that. And so this issue, I think, going forward, we need to be cognizant of, is the data that we're seeing, is it coming from a third party? Has it been verified? Has it been looked over? As opposed to a randomized controlled trial where the authors are in perfect control of their own data. They know what their data is and they can publish that data and show that data. And obviously sometimes they do that in the supplements, and so you can review the data as well. So I think, Kyle, that's really the specifics on this particular case. This was a study that used a particular way of getting the data through electronic health records in a very complicated third-party surrogate way that opened up the door for people not being able to see that data as clearly as they wanted to, and because of that, the papers were pulled down.
Okay, moving to another question here from Patricia Hoke and many others that are wondering about viral load and infectious dose. And do we know much about viral load? So if you get more of the virus at once when you get infected, are you going to have a more severe COVID-19 disease? Do we know much about viral load with COVID-19? And if not, what do we know about other coronaviruses or other viruses as it relates to viral load?
Yeah, so we know it seems reasonable at least to understand that it works the same with SARS-CoV-2, that the larger load of virus that you get, the more likely you are to get a serious infection. It's kind of the basis behind why you wear an N95 mask, right? So an N95 mask takes out 95% of the particles. There's going to be slight particles that get in there, but if it's low enough, the body can sort of take care of those. There's actually even N100 masks as well. Those are a little bit more difficult to breathe. It's harder to move air through an N100 mask than it is through an N95 mask. And so you've got to sort of find the right balance there. But yeah, certainly the short answer to that question is the more virus that you're exposed to, the more of a chance of a worse infection. This is the same, by the way, for bacteria. The larger of an inoculation of bacteria that you get, the more likely you are to get an infection, and the severity of the infection is going to worsen as well.
I'm putting you on the spot with this one, Dr. Seheult, because I know you haven't had, you've been working in the ICU this week and you haven't had a lot of time to review this, but the MAF Plus protocol, a lot of folks wondering about that. I think some folks, some clinicians watching are already using this. What are your initial thoughts on this?
Good question. So MAF Plus, that's a steroid. M stands for methylprednisolone.
Yes.
And the A stands for the
that's
ascorbic acid, which is a vitamin C. And the T is the thiamine. That is the IV as well. And the H is the hydroxy, or the what does the H stand for again?
I'm looking this up here.
It's hydrocortisone, I believe. No, that's the methylprednisolone.
I
know
heparin.
Where it's coming from.
It's heparin.
Heparin, that's right. Yes. That's right. It's heparin. So I know it's coming out of Virginia, and Dr. Pulmonary group is looking at this. He is a big proponent of vitamin C, and for good reason. I think vitamin C can be used here. It's certainly shown some benefit in septic shock, in some case control trials, not yet in a randomized controlled trial. It has shown some benefit in the use in ARDS, which certainly we're using that. There was the Citrus Alley trial where they used high doses of vitamin C, and as a secondary endpoint, believe it or not, mortality actually improved. Steroids, so that's the M. Early on, people felt that steroids in COVID-19 would not be a good idea because they thought it would prolong viral shedding. That was in the early days. I don't think there's really been a good data set on that to say whether or not that is truly the case. So I don't begrudge them for using steroids. It certainly makes sense, especially in a situation where you've got post-inflammatory situations like the storm and pneumonia. Don't begrudge them at all in terms of vitamin C. So the M makes sense. The A makes sense. The T obviously makes sense because you need the thiamine to prevent the kidney stones that you might get with vitamin C. So that makes sense. The H, heparin, yeah, we've talked about blood clots. So MAF Plus, and the plus being just basically anything else that you might need, like zinc or vitamin D, etc. We're using that. We're using that in our facility, minus the M. I don't think we've gotten really signed on board yet to the steroids. I think that we're sort of coming around to that, but certainly the A, the T, the H, and the plus, certainly using that at this point. The plus, we're definitely using plasma, convalescent plasma. We are using remdesivir when there's no contraindications, specifically renal insufficiency. And tocilizumab, which is the IL-6 inhibitor, that's also being used as well. So I think everything right now is pretty much on the table, so long as it doesn't cause a lot of side effects.
Thank you. Elaf Salim wants to know, if you have a patient in the ICU with COVID-19 or in the hospital with COVID-19 and they have thrombosis and cytokine storm, what type of medications are you giving for treatment, or what are you doing for treatment? And then any recommendations for prevention?
Yeah, again, we don't have any randomized controlled trials on this. So what are we doing? We're trying to do stuff that we think might be helpful. So heparin drip is probably one of the things that we would do for thrombosis. In terms of cytokine storm, tocilizumab, I've heard that there's a cutoff of ferritin being greater than 500. If the ferritin is greater than 500, then it seems as though tocilizumab may be a good medication to try. We're tracking CRPs, we're tracking ferritin levels, we're tracking D-dimer levels, BNP levels. I mentioned CRP as well. We're tracking all of these things, and generally these things all sort of go up or they all sort of come down as in unison, and so that is what we're using.
Great. Let's see here. Kimberly West has a question about asymptomatic carriers and just the implications of this. And is it, I'll add, is it different than other viruses that we're familiar with, like influenza?
It's very different. You know, influenza we can pretty much stamp out because we can know whether or not the patient has symptoms. I mean, there are some people that have symptoms and there's some people that don't, but by far and large, most of the people have symptoms. This is completely different than SARS-CoV-1. All of those patients had symptoms, fever. We could pretty much lock it down based on fever. We haven't been able to do that. So this is really a head scratcher. One of the thoughts could be that the viral proteins are suppressing the immune response and fever, and that's why we have these asymptomatic carriers that are walking around spreading the virus person to person. And that's certainly a possibility.
So at the start, we talked about there's almost 2,000 trials going on right now. A lot of questions about medications. A lot of them, you know, we really just need to wait and see. We don't have preliminary data from these. But what are some of the trials that you're really just keeping your eye on at this time and anticipating the results?
Well, aside from the vaccines, Moderna, Johnson & Johnson, AstraZeneca, Oxford study, these are the big vaccine trials that we're all sort of looking at and waiting for. What we're looking at right now is we're looking at, you know, I would like to see a randomized placebo-controlled trial of hydroxychloroquine and zinc. That's what I'd like to see. I think they're doing that. I'd like to see a randomized placebo-controlled trial of quercetin, which is being done. There's a couple of scientists, as we've talked about before, Canada, China, that are being looking at this in China. I'd like to see the randomized placebo-controlled trial data on tocilizumab. I'd like to see it on plasma. I'd like to see it on zinc. I'd like to see it on vitamin D. All of these trials, I'd love to see the data on it. And, you know, I personally believe that it's not going to be just one magic bullet. It's going to be a number of these things because these things work in different phases of the disease. Obviously, remdesivir and COVID and convalescent plasma are going to be working near the front end because these are things that deal with the infection itself, reduce the viral replication. But things like tocilizumab, which is an anti-storm medication, it's an anti-immunity, it's an anti-IL-6. These are things that are going to be, you know, treatment further on down the line as you're trying to pick up the pieces of the body as it's being attacked by the immune system and pneumonia and stuff. So I think it's going to be a multifaceted approach. There isn't going to be just one thing that's going to be working.
I had a question here from Tammy D. How high are the levels you are seeing for CRP and D-dimer? So I'll add to that. Can you please explain, and again, review for the clinicians that are watching this, but can you explain what those tests are as well?
So CRP is a C-reactive protein. It's an acute phase reactant. It goes up with inflammation. You know, generally speaking, it's 1 or 2, 5 maybe elevated. I've seen up to 30. So it's a dramatic inflammatory situation. D-dimer, of course, is the byproduct of coagulation. And when we see an elevated D-dimer level, we think, well, maybe there's thrombosis that's occurring. Normal in our lab is 0.5. If it's less than 0.5, then it's negative. I'm seeing as high as 35 D-dimer levels. So obviously tremendously elevated levels here, Kyle. It's quite impressive. We can almost tell immediately if this patient has advanced COVID-19 without even doing the test. You run these tests, and if they're elevated, it's almost without exception, they've got low lymphocytes, they've got elevated CRP, elevated D-dimer levels, and elevated ferritin, which is another acute phase reactant, has really not much to do with iron store, although it does store iron, but you just see ferritin go up in just about any kind of infection.
Great. Well, Dr. Seheult, we are right about at time, and want to turn it over to you. Any other things that you want to share?
No, we are really in the thick of it. We're in this period of time where we've got a bunch of things that may work. We don't know for sure if they do. We've got remdesivir, we've got plasma, convalescent plasma that we're using, and things are starting to solidify. We're starting to get a little bit better picture about what it is that we're dealing with. And now that we're opening, quote unquote, opening in this country, I believe we're going to start to see a little bit more. This is now 3 weeks after Mother's Day, plus or minus. When we get to 3 weeks after the opening up, 3 weeks after the riots that we've been having here, that's when we're going to really have to take stock about where we are in terms of what our capacity is, what our PPE is, and the rest of things.
Well, thanks so much, Dr. Seheult, and look forward to doing some more updates this week and getting those uploaded. And we'll try to do this again next Sunday if that works with you.
Yeah, absolutely. Join us over at medcram.com as well. Whenever you're feeling kind of lonely out there on YouTube and there isn't an update, just join us over at medcram.com.
And for viewers that are new to us, could you give a quick 15-second plug about what medcram.com is and what kind of videos we have there?
So while we love to broadcast to YouTube as well, because it's a big, broad audience, medcram.com is really our own environment that we've got full control over. We've got all our videos published there, ad-free. We also have a number of courses. Kyle and I were doing this long before COVID-19, trying to explain to healthcare providers and also lay people about medicine and medicine in general. We've got EKG classes over there. We've got how to manipulate ventilators for patients, how to read a pulmonary function test, for instance, information about how to interpret CBC. And we have a number of other courses that are coming online in terms of complete metabolic panels and things of that nature.
Excellent. Well, thanks, Dr. Seheult. Thank you to all of you for tuning in tonight and for your questions. And we try to read as many of them as we can. And we'll try to do this again next week. So hopefully see you then. Thank you.
Thanks, Kyle.
Thank you, Roger.
Yep.